This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. We're back with part 2 of our discussion with Ayush Gupta from the Department of Neurological Sciences at the University of Nebraska Medical Center and Kuntal Sen from the Division of Neurogenetics and Neurodevelopmental Pediatrics at Children's National Hospital in Washington, D.C. We have been talking about their recent review paper in Neurology Genetics on monogenic mimics of neuroinflammatory phenotypes in children and young adults. Do look that paper up. Listen to part 1. They are walking us through all of the phenotypes that we often see when we're considering central nervous system inflammatory or demyelinating disease and what genetic conditions might be seen in those who aren't precisely meeting the diagnoses. So in the first episode, we talked about supratentorial white matter disease, encephalitis-like presentations, even brainstem disease. Ayush, can we pick up this time and shift to the spinal cord? When a patient presents with a transverse myelitis, as they call it, but more accurately, perhaps we should say myelopathy, what imaging or clinical features should make us think of a possible genetic mimicker in those myelopathy patients?
There are several genetic mimics that can present with those features on imaging that can be very distinctive. One of those disorders is something called LBSL, leukoencephalopathy with brainstem and spinal cord involvement with lactate elevation. I know it's a very long eponym, but LBSL for short. It preferentially involves the dorsal columns and lateral corticospinal tract, producing what we call as longitudinally extensive transverse myelopathy-like presentation. The key is that these lesions are very symmetric, and sometimes they can extend all the way to the dorsal medulla and midbrain. And as the term implies, LBSL pretty much always has lactate elevation. So if you see lactate elevation in a patient in CSF where these kind of findings are present, think about LBSL. The other important clinical clue is that these patients present with a progressive myelopathy-like presentation rather than acute myelitis-like presentation. So usually it falls into more of a mimicker of something called like progressive multiple sclerosis, where they have progressive history of gait difficulties, spasticity, or ataxia, sometimes going back years. And the other mimicker that is actually more relevant to our adult colleagues is something called as late onset Alexander's disease, which for reasons that are not completely understood, does not present like a typical leukodystrophy that we see in childhood. It affects medulla and spinal cord and causes atrophy. So typical imaging sign is described as tadpole-like appearance on MRI, and that could be an indicator for a late onset Alexander disease. I want to highlight this because this illustrates an important principle. And as we discussed before, many monogenic disorders, they show age-dependent phenotypes. I'm talking about, for example, leukodystrophies, where in pediatric age group, there is a severe presentation with much more spasticity, ataxia, etc. But in adult age group, it can be somewhat slower and milder presentation, sometimes just restricted to cognitive or neuropsychiatric type presentation. And as we discussed in our prior podcast, Aicardi-Goutieres syndrome can also vary from classic infantile encephalopathy to a picture which is dominated by just a movement disorder in older patients. So there is a very important lesson to learn here that not all myelopathies are going to be autoimmune or acquired, but also we have to keep in mind that there are patterns of certain leukodystrophies and genetic disorders which can be very widely different when compared between adult and pediatrics.
That's such an incredibly important point, right? Because you think about how we learn and how we're trained. When we take our neurology board exams, the pediatric portion focuses on those classical presentations, especially of the leukodystrophies. And when we're seeing a young adult patient in front of us, we are referencing back and going, can't be that, right? Because it doesn't fit what we were taught. And this is really the sort of bleeding edge of this, right? Is what are those phenotypes once you get outside the early, very dramatic classical presentations? And that's a really high risk scenario for these patients who don't present classically, who don't present very young, to be lost because there's this sort of gap of what would you present with. And on the flip side, you might get a genetic variant if you were suspicious enough to send genetic testing. And this is another area where if we don't understand fully, is that variant functional? Is it relevant in this patient? And may tend to say, oh, it's just a variant that's not significant because the phenotype doesn't fit what we think it should. Am I saying things that you see commonly? Because I feel like this is what I face in clinic when I'm evaluating these rare disease patients. And it's an area where there's a dearth of guidance.
Yes, from my perspective, there's always this gray area, different variants of uncertain significance where we are like, is this a genetic disorder or is it not? The picture and the clinical picture is not very concordant with what is described. But then that's the very important timeline where we have to look back, stop, and maybe reach out to our neurogenetics colleagues like Kuntal.
Yeah, I 100% agree. I mean, there are two different things here. A, you get a clear pathogenic or a likely pathogenic variant in a gene, which is associated with a dramatic pediatric disorder, but your patient has an atypical course and is like an adult. And that is something we encounter very commonly because every monogenic disorder comes in a spectrum, and there is what we call genotype-phenotype correlation. So based on the exact mutation, the protein can be affected to different extent. So you can have different manifestations, different ages of onset. And the other thing which Ayush alluded to is variants of uncertain significance. So sometimes there might be an answer hiding in a variant of uncertain significance. And that's when we really want to do a thorough research, see if there's a functional study to confirm the pathogenicity. But at the same time, we don't want you to overinterpret your variants of uncertain significance and give away a diagnosis which is not true. So yeah, this is an incredibly important area of discussion.
Yeah, and you are also hitting the tip of the iceberg, as I understand it, with my limited genetics knowledge too. But something we didn't specifically call out is that for many of us on the adult side, panel testing is much more affordable for our patients. So we can't get that whole genome sequencing necessarily. That may be out of reach financially because coverage is so limited, but we might be able to get a panel test. And we didn't even really get into this, but there's this whole concept of compound heterozygosity. Can you explain that to us a little bit?
Yeah. Compound heterozygous variants, it's a concept in autosomal recessive disorders. So for autosomal recessive disorders, you need two mutations or two pathogenic variants in each of your alleles. And there is two ways one can have an autosomal recessive disorder. It can be a homozygous mutation where both the alleles have the exact same mutation. And that is seen commonly in patients from consanguineous families or from a small village, because having shared ancestors increases your chance of being carriers of the same disorder. And the second thing is compound heterozygous mutations, where the two alleles have two different mutations, and they essentially lead to having autosomal recessive disorder because neither copies are working.
And this I bring up specifically, I've had to phone a friend, as you say, in neurogenetics sometimes where I've gotten one hit on a panel test because they didn't look in depth to find multiple hits on that same mutation area. And I felt the VOS fit. I knew it was insufficient given the autosomal recessive nature of it. And really, this has required just advanced expertise and testing from neurogeneticists. So this is just another area, perhaps even more relevant to us in the adult world, where we are trying to get this testing done on a budget, if you will, but just another pitfall that I've personally encountered and one that just requires patience, time.
Yeah, that's so important. And thank you for being so thorough and going above and beyond for your patient. You're right. Sometimes you would get a heterozygous variant in an autosomal recessive disorder, and it really fits, but you don't have that second mutation. So you have to think about what are the limitations of your genetic test. So if you have sent a panel or even an exome, there are certain things which could be missed on the other allele. So for example, if it's an exonic deletion or duplication, typically panels would miss that because they only look for single nucleotide variants. The second thing is if it's a deep intronic variant, which would be picked up only on a genome. Or if it's a trinucleotide repeat variant and not a single nucleotide variant, those are things that can be missed. So it's very important to educate yourself about what are the limitations of a test and the phenotype better than your genetics colleagues. So if you really think that the phenotype matches, phoning a friend and then going above and beyond to do advanced testing like transcriptomics, long read sequencing, and functional studies would be really important, because this is not just for academic or research interest, right? Like, this is actually going to change the trajectory for your patient. So kudos for doing that.
We have to, right? It's the right thing to do. The one that comes to my mind which most prominently, where I had some help from our colleagues at NIH, was a CTLA-4 haploinsufficiency, where a panel test caught half, but not quite enough. And they were able to fill that in for me, not to even get into sort of the challenges around what if you have to try to get this done through insurance. The other thing that you and others in neurogenetics have taught me is that the question matters so much. So in the instances when I have been able to obtain the whole genome sequencing, it really matters what is filled out on that intake form, right? I had one patient who came to me and she had the whole genome done prior to seeing me. And the questioning was all focused on her hypermobility and her connective tissue concerns. And what wasn't mentioned in there, and so the geneticist analyzing the variants didn't know, was her profound immune phenotype in terms of immunodeficiency and superimposed autoimmunity. And so when I was able to go back to that geneticist, that really opened up an entirely new investigation and brought some of those variants into focus that were otherwise irrelevant when it was just being phrased as a connective tissue problem. Have you seen that happen as well?
Yeah, you bring up a very important point, Stacey. So what you're referring to is, what is the phenotypic description on your exome test requisition form? And that's so important, because when you are sequencing 18,000 genes, you are generating a ginormous amount of data. And those molecular geneticists, they have to filter through hundreds of variants. So as a clinician, it's really important to describe your phenotype accurately. For example, if your requisition form says a 5-year-old CP versus a 5-year-old with spastic diaplegia, lactic acidosis, bilateral deep nuclei changes, your yield changes. And we have encountered many such cases. For example, recently, one of my colleagues, Dr. Borger, published a case where a child presented with dystonia, but the requisition form mentioned spasticity. So the exome came back as negative, but in the second page of the exome, they mentioned 2 variants in GCH1, which is associated with a form of dopa-responsive dystonia. It was just like a partially described phenotype, but when we took a look at it again, that was the answer, and that was confirmed with biochemical testing, and the patient responded to dopa supplementation. So this story has been told many times. It's really important to work with your genetics colleagues and your genetic counselors to make sure you are focusing on the right phenotype. And it's even more important in adults, because in a child, the phenotype is relatively clean. But when you have an adult, you have so many things muddying the picture, like hypertension and diabetes, and those are very unlikely to have a monogenic etiology. So you'll have to be really astute and know which is the exact phenotype where you are wanting an answer for.
Yeah, this is a lesson I've been taught, and now I never outsource, if you will, that piece of paperwork, because it is quite time consuming, but it's certainly not for staff or trainees. This is a critical piece of the question, right? This very expensive testing in some cases can be rendered far less useful if I'm not providing everything that I know about the phenotype. Because in a sense, I'm asking this genetic testing to answer for me or provide for me something I don't know, right? It's the age old, we don't know what we don't know. And so the more data that I can put into there, the more likely I am to learn something, to find a relevant mutation that I most likely have not previously heard of. That's a helpful explanation to hear it coming from you. I'm going to shift gears back. Ayush, I promised we were going to get back to some of these useful pearls, and I don't want to let you go until I ask you more questions. So let's talk about the visual system. So optic neuropathy or optic neuritis is another area that you cover in the paper where anchoring bias is quite common. So when should we, as neurology clinicians, be thinking about changing our diagnosis from a run-of-the-mill idiopathic optic neuritis?
One of the disorders that comes to mind in such scenarios, which is genetic, is a Leber's hereditary optic neuropathy, or LHON for short. There are certain features that can help us distinguish between inflammatory type optic neuritis versus optic neuropathy related to LHON. Visual loss, if it's painless, if it's bilateral, or if it's quickly sequential, like a patient had a vision loss in one eye and in a month or so there is the other eye involvement and more severe and persistent involvement that you will expect from a typical demyelinating optic neuritis. On imaging, you can have different presentations of LHON. MRI may show minimal or absent optic nerve enhancement, but sometimes you can also have T2 flare hyperintensity in the optic nerve and enhancement even with LHON. The key is the patients do not improve on high dose steroids. In our case that we presented in the paper, there was some contrast enhancement, which was exception rather than a rule for LHON. And then family history is very important because this is a mitochondrial disorder, so it is inherited from a patient's mother. Maternal family history of vision loss can be a very important indicator. Another fun fact about LHON is that sometimes you can have LHON with a concomitant autoimmune demyelination disorder. There's an eponym associated with it called as Harding's disease, where you have both LHON causing optic neuritis, but also demyelinating lesions in the brain. And the phenotype is actually interesting because it is thought that the mitochondrial injury that happens in the optic nerves causes release of the cell products and triggers secondary autoimmunity. LHON and LHON plus disorders, as they are called, can be an important differential when you are thinking of optic neuritis from a monogenic perspective.
And this is helping me with my framework as you talk. When we get those poorly responsive or no improvement patients, the time to really look for that would be once we've determined, oh, this is a poor response. I really thought you would do better. And probably before we look for the other diagnosis that I see once or twice a year, which is an optic nerve glioma, because that, of course, requires tissue, and we wouldn't want to go in for that tissue. We know that's always a high-risk procedure. So really making sure to slot in that Leber's testing after we've determined an atypical or poor response, and then before we would consider pursuing a biopsy is what I'm taking from what you said in terms of practical steps in my framework. Still thinking about optic neuritis, optic neuropathy, but combining it now with myelopathy, I want to ask you about one that is always on the back of my mind, and you mentioned in the article. Can you talk to us about this biotinidase deficiency, and can this present in children and adults or partially? What does this look like in terms of the full spectrum? I'm always looking for this one.
Yeah, so this is again another challenging diagnosis. Biotinidase deficiency disorder is part of newborn screen, so you will expect most of the patients to be picked up by that. But then you have certain variants where you have partial deficiency, which is not enough to be picked up, and those patients can mimic the optico-spinal syndrome that we see with neuromyelitis optica or a MOG-associated disorder. And this is something which is also not a absolute no miss disorder, because it's a very treatable disorder with biotin supplementation if we recognize early. Any child, or even in fact a young adult that presents with optico-spinal syndrome with the setting of hearing loss or a skin finding of rash, that could be suggestive of biotinidase deficiency. What you do in those cases is send blood testing for biotinidase activity, and then you make the diagnosis. There are other metabolic mimickers of this opticospinal syndrome too, which we have not gone through in our paper, but briefly, opticobulbar syndrome, where you have optic atrophy and cranial neuropathies from the brainstem, along with neuropathy, should lead the neurologist to be concerned about a disorder called as riboflavin cofactor deficiency. It's also a very treatable disorder with high-dose riboflavin, and there can be some dramatic improvement in these patients. And then last group of the disorders that can present with that is complement deficiencies, which can present with extensive myelitis. Now, this is, again, one of those disorders where you have interface between a genetic disorder and the inflammation.
Ayush, you present it beautifully. I'm putting them all in my mind. I'm going to run a quick case by you because I remain stumped by this one. I don't necessarily know if you'll have an answer either, but I had a patient come to me as a seronegative NMO, an adult, and I've been treating her for a couple of years. And I keep looking at every visit, as I do with anyone who comes in with that seronegative label, for the real cause, if you will. You don't have the antibodies, you have a phenotype, though. And in this patient, she was a few visits in, and she was just talking to me about general symptomatic issues and was complaining about a rash that would come and go, particularly in the winter around her mouth. I'm not a dermatologist, so I started searching and using resources in the room right there with her and came up with, biotin deficiency can do this. And immediately in my mind, I thought, oh my goodness, I've never checked her biotin level. And sure enough, it came back as undetectable. And I thought, oh my goodness, is this in fact a biotinidase deficiency? But then I went to have the biotinidase level checked. And as I recall, you have a matched control. So it's like whoever you bring with you to the appointment also gets it drawn because it's a sensitive assay. Sure enough, the biotinidase assay came back normal. And nonetheless, the biotin was undetectable. So I started replacing that. Easy thing to do. Where does that leave me? It was very unsatisfying because I wanted to see, oh yeah, you have this biotinidase deficiency. And wouldn't that wrap everything up neatly in terms of explaining the seronegative NMO? Do you see this happening?
Yeah, sometimes, of course, it's not very common, but again, like Kuntal talked about, when you have a specific metabolic test that's available, you want to correlate with clinical findings, imaging findings, but also genetic testing. So one of the takeaways that we highlight in our paper is how we should also test the phenotype and genotype and put them together. So maybe in this case, if we do genetic testing and that determines biotinase related alleles that are having some pathogenic variants, then that will concord the diagnosis, and then this is indeed biotinase deficiency. The other part is a response to treatment. The key for many of these disorders is to start early and treat early, because if you don't do that, then the disease can be already progressing, and many of the defects that were happening will be irreversible. So it's a hard case, but again, we have to make sure that we are checking a list rather than biasing or anchoring ourselves to just one specific test. The other disorder that comes to my mind with the rash type of presentation is a Michel syndrome or ACOG's related disorder that can also present with a rash which almost mimics like ichthyosis. And then the other disorder to look about is, again, the interferonopathies. A lot of them can present with rash, which can be looking like a vasculitis or can be looking like eczema as well.
The more cases I present to you, the more genetic mutations come flying out of your brain. I love this. It's quite useful and really raises the point. We don't have to know all of the mutations, especially in the age of AI. This is actually one application I've found when I'm out of clinic, finalizing my notes that evening. I often can do a search and it can reveal other things that I may not have thought about. But when I am making note of all the abnormalities, I found that to be useful in case I can't text you, Ayush, all day long. And I appreciate your practical approach to this, right? There's multiple layers, multiple levels of testing. Kuntal, once a neurologist starts thinking genetic, all these things we've covered in the discussion, this can feel very overwhelming, crammed into our short clinic visit. What is a practical framework for approaching this testing with or without having ready access to a neurogeneticist? And how on earth do we get it covered by insurance?
I don't know if I have a easy answer or a solution that will fit every institution, every clinician, but we have to advocate for this and we'll have to come up with tailor-made solutions for our own clinics. So the first thing is genetic testing is something that's a tool in your toolkit, just like MRI and EEG and lumbar puncture. So you have to understand that and own that. And it can't be this thing which neurogeneticists and medical geneticists do. Once you understand and own that, I think things become easier. So you'll have to work collaboratively with genetic counselors and neurogeneticists. But one thing we want adult and pediatric neurologists to feel comfortable with is doing the pre-test counseling, ordering the test, and getting the process started for results interpretation. So if your phenotype is such that you're highly suspicious of one particular group of disorders, such as leukodystrophy or Leber's optic neuropathy, you can send a targeted panel. But in the world of neurogenetics, we are moving more and more towards exome and genome first, because it's a very broad and extensive test. When you send this test, it's important to work with your genetic counselor to make sure that you have appropriately counseled the family. So, talking about possible outcomes, the possibility of unexpected findings like non paternity, and secondary findings such as cancer genes and cardiomyopathy genes, all of those need to be talked about during the counseling session. And it's also important for clinicians to remember that exome and genome does not check for everything. So you have to concurrently do biochemical testing with lactic acid, ammonia, plasma amino acid, because many a times this will help you resolve a variant of uncertain significance. And we previously talked about certain types of genetic disorders which would be missed on an exome. So for things like mtDNA disorders, trinucleotide repeats, and microdeletion syndrome, those would not be picked up on your exome sequencing. The cost effectiveness of these tests, it's very important. And ideally, we would like to go through insurance and justify in our clinical note why this is so important. But many a times you might get insurance rejection. So during such situations, a lot of these companies will have patient support programs where they might be able to pay something out of pocket, say $500 or $1,000, and might be able to get the testing done without going through insurance. So there are many such ways to troubleshoot, which is another important reason to hire genetic counselors within your division, because they really are very resourceful and know how to delve into this process as well as counsel your patients.
Genetic testing accessibility, even in adult population, it's becoming increasingly more affordable as the tests get more advanced. In my clinic, when I have patients who have a white matter disorder presentation as adults, I tend to order more and more whole exome or whole genome sequencing. And the other component is family segregation that we didn't discuss. Family segregation means that we can test the parents of the proband simultaneously. In that way, we can analyze what are the traits or the variants that are coming from parents or not. And that can help us also streamline where we can think of a specific genetic disorder.
I will say, at least in my practice, we don't have enough genetic counselors to embed in every clinic, but even just having them there as a reference, they've been able to teach many of us the basics of this. So we don't have to call them for every single patient. And that's really a way to maximize the impact of a specialty, genetic counseling and geneticists as well, that we're never going to have enough of. So really even just learning and incorporating it into practice. This is such a relevant point you make. We really need to recognize that as neurologists, we have to take a little bit of ownership of this. We can't just say, oh, you should go see somebody to think about genetic testing. We really have to get those wheels moving. So I understood and I agree with and appreciate that message.
Absolutely. Yeah, that's the take-home message, that every pediatric and adult neurologist needs to feel equipped with the basic knowledge of genetic testing. And our group has done a lot of work to demystify genetic testing. So we released a curriculum in genetic testing through the Child Neurology Society, and we are now doing an annual workshop known as the Genetic Summit, where our goal is to demystify and simplify this process. And every neurologist needs to be able to look at their genetic testing report just like they would look at their MRIs and EEGs. Ultimately, you will have to collaboratively work with experts in neurogenetics, but if there's a waiting time, we do want you to get the process started for effective patient care.
Really useful. And that summit, is that also with the Child Neurology Society?
That is correct. Both the curriculum and the summit are through the CNS, but I also chair the neurogenetics section of AAN. So we have a lot of overlapping educational webinars and educational processes, which will be available to AAN members as well.
Ayush, I could pick your brain all day long, but overall, can you tell me what it is that you have seen that you wish all practicing neurology clinicians knew to get us closer to picking up all of these patients who are no doubt lurking in our clinics?
That is the main objective of this paper. And I think the single most important principle here is don't force an autoimmune label on a disease that does not behave like one. When you have these red flag signs that we have delineated, like early age developmental issues, strong family history, something that's not matching in terms of imaging or CSF. And if there is progression and not responsive to immunosuppression, then you should stop, take a step back, and ask, could this be monogenic? Keep a mental checklist. Make sure that you have people to reach out to, especially genetic counselors, neurogeneticists, who can guide you for further diagnostics. And the last thing is, with availability of more technology and resources and testing, rare diseases are not rare when combined together. So think of it as an opportunity to give something back to the science, to give something back to the people and the patients in terms of helping them in their lifelong journey of dealing with a rare disease.
Beautifully said. Thank you both for walking us through this. It's a very practical, very relevant, and really important discussion. Again, I've been speaking with Ayush Gupta and Kuntal Sen, co-authors on the recent Neurology Genetics review titled Monogenic Mimics of Neuroinflammatory Phenotypes in Children and Young Adults, an Evolving Landscape. This is a very important paper to print out and read. They have several great examples, many of which we covered today, but others as well. Thank you again.
Thank you so much. This was a really good experience for me.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.